So we've had a really good look kind of back there, and I want to switch gears a little bit and look to where things stand today. Maria, what do you see as the most pressing challenges faced by advocacy groups today? So having kind of moved from that earlier picture, what does today look like for you, and what are those biggest challenges?
Without a doubt, the rarity of many mitochondrial diseases and a lack of awareness about mitochondria and mitochondrial diseases still proves a huge challenge, not only to patients and families, but also to advocacy groups. And this is despite the advances in genetic testing and the fact that in the UK, we're lucky enough to have an NHS commissioned, highly specialised service for mitochondrial disorders. We know that there is still a lack of awareness of mitochondrial disease amongst non-specialist professionals, like Amel's just been speaking about, which means that for many patients, the journey to diagnosis can still be incredibly long. The fact that mitochondrial diseases can affect any organ and strike at any age means that the clinical presentations can vary hugely, and particularly amongst adults, they can really struggle for many years with a lot of different symptoms before a clinician can sort of join the dots and start to really think about mitochondrial disease as a potential diagnosis. Raising awareness of the signs and symptoms of mitochondrial disease amongst GPs and non-specialist professionals is therefore something that remains a challenge as well as a priority for us as a patient advocacy group. Additionally, mitochondrial disease is actually an umbrella term for a range of different disorders. And we know that there are a huge number of genes that can be responsible for actually causing mitochondrial disease across both the nuclear and the mitochondrial disease genes. And it's unlikely that there is going to be a one-size-fits-all approach for both diagnosis and treatments of mitochondrial disease. And we're actually learning about new disease-causing variations all the time. And that's why projects like in the UK, we have our Precision Medicine Diagnostics Project, which Lilly are funding, which uses cutting-edge techniques to identify new disease-causing genes. And that's so important so that we can continue to increase those rates of diagnosis for mitochondrial disease as a first step towards management and hopefully eventual treatments. But even once patients are diagnosed, the lack of standardized care pathways for patients to follow is something that many families can find really difficult. Not every patient currently has access to a specialist team for mitochondrial diseases in the UK, and having a condition that many doctors have never actually heard of can be incredibly isolating and actually, from what we hear from patients, a very frightening experience. And finally, sort of the rarity of mitochondrial diseases also proves quite a big challenge in terms of actually funding research into understanding and actually treating these conditions. And whilst in recent years we've seen an increasing levels of interest in the pharmaceutical industry, we know that we are still competing against many much more well-known diseases for quite limited pots of funding. And for us as a rare disease organisation, we rely really heavily on our incredible mitochondrial disease community in terms of fundraising, and every penny of that sort of goes back directly into supporting these families and furthering research into the condition. So there's a lot of challenges still ongoing.
Yeah, clear that diagnosis is still remains a big challenge there. Is there a role, Paula, in legislation here? And if so, how might that have impacted families?
Yes, well, recent changes in healthcare legislation, particularly in countries like the US and Europe, have focused on expanding access to treatment and reducing barriers for individuals with rare diseases. The Affordable Care Act, the ACA, for instance, included provisions that prevented insurance from denying coverage based on pre-existing conditions, which is crucial for mitochondrial disease patients. Prior to this, many were either denied insurance or faced really high premiums due to the complexity and long-term nature of their conditions. Furthermore, some recent legislative efforts have expanded the scope of Medicaid, increasing the number of patients who can access vital treatments in specialized treatment for mitochondrial diseases, including, for example, physical therapy, nutritional support, and mitochondrial-specific treatments such as gene therapy trials. Rare disease legislation and research funding is another issue, is another key area of impact, which comes from increased government support for research. The Rare Disease Act and the Orphan Drug Act have led to the Rare Disease and the Orphan Act have led to an increased funding for research into mitochondrial diseases, helping to advance scientific understanding and providing hope for future treatments. This also includes initiatives to expedite the approval of new drugs specifically for rare diseases. Families affected by mitochondrial disorders are benefiting from this growing focus on rare disease research as more targeted treatment and potential cures emerge. We also have to keep in mind the disability and family support, which is growing more and more. Legislative changes around disability benefits have also been vital. Recent updates to Social Security disability insurance, SSDI, and supplemental security income, SSI regulations have made it easier for mitochondrial disease patients to qualify for financial assistance. For families, this means less financial strain in caring for loved ones who require constant care, therapy, and often specialized equipment. In some cases, families now have better access to respite care and to caregivers and to supply to caregivers. Another challenge, there are still challenges. Another very interesting thing is we talked about it before, the mitochondrial disease replacement therapy, which is already legal in the United Kingdom. It has been legalized in 2022 in Australia, and the delegation law was passed in Italy last year. And we're looking forward to having it approved in Italy as well.
Oh, so amazing to hear that there really are some things that are happening on the ground that are making big and significant impact changes to families. And especially in the sort of the landscape of treatments and social care, which of course is really important. But going back to what Maria was saying, Amel, about the diagnostic challenges, if we kind of look a little bit more at the science of that, what are the challenges to diagnosis? Like, what are the key genetic markers that indicate the presence of a mitochondrial disease? And what are those key challenges in diagnosing them when we've got such a complex array of genes to look out for? You know, what part is that playing in this complex element of connecting patients with a diagnosis?
Yes, sure. So mitochondrial diseases are first clinically suspected by the symptoms the patient presents with. They can be screened for by doing some blood tests, MRIs, imaging of the brain, and other things. But the only way to confirm a mitochondrial disease in 2025 is to find a specific genetic marker that has been linked to a gene that, when affected by a change in the underlying DNA, is known to cause a mitochondrial disease. So one of the complexities of these diagnoses is that mitochondria is a very complex organelle. It has two sets of DNA blueprints, two genomes, one that is maternally inherited, that is transmitted within the mitochondria itself. It's a small genome, a small set of DNA, and we know that it codes for about 37 proteins or genes. And we have the larger subset of the DNA that is transmitted through chromosomes by 50% from the mother and 50% from the father. And those hold about 400 different genes that have been directly implicated in mitochondrial function. So any change in that DNA within the mitochondrial DNA that holds 37 genes, or that nuclear DNA that holds 400 different genes, can lead to mitochondrial disease. So when we talk about doing genetic testing, we really have to cover both DNA sets. So that's the first challenge. Do you have access to testing that covers all of the genes? And nowadays, the most comprehensive testing is something called whole exome sequencing or whole genome sequencing, which is available in a lot of places, but not everywhere. So not every patient will have access to it. And the second big challenge is that even if there's access to these genetic testing, the cost is very high in a lot of the countries, and getting that reimbursed by insurance is not very often possible. And so a lot of patients, even though they know there's access to the testing, they cannot afford to get the testing and to get their disease diagnosed. And so the third challenge is that even after you are able to pay for the test and you get the test, the results can come back very inconclusive, which means that the best case scenario, you get a report that finds a change in a gene that has been already linked to a mitochondrial disease, and you have a positive test, and we can put a name to what the patient has. Sometimes the result come back negative. So we looked at all 37 plus 400 genes, and we can't find a change that explains the disease. And that's because either the patient has something else that is not mitochondrial, or that the patient has a mitochondrial disease that is caused by a gene that we don't even know about yet, that hasn't been studied yet, that hasn't been linked to mitochondrial disease. So those patients are still not done with their diagnostic odyssey. And the third case scenario is that we find changes in some of these genes, but we cannot interpret them because the science is limiting our understanding of how these changes work. And unfortunately for those patients and their families, we have to wait for science to catch up with us. And so we have to revisit that genetic testing after a year, after 2 years, after 3 years, until we figure out, either through research or a project, or through other families being diagnosed with the same thing, harboring the same symptoms, that change is really causing the mitochondrial disease. So these are the challenges with genetics.
So Phil, from your perspective, obviously with over, I think, did you say 400 different genes involved there? How does the clinical presentation inform the diagnostic approach? And it might tie into a question that we've been asked by one of the audience as well, as, when you're presenting in a hospital setting or with a GP, how does that then filter into what that approach would look like?
Yeah, the word complexity has come up, right? Multiple times here. You included it in the title.
It's in the title, yeah.
And just listening to Amel describe the genetics of mitochondrial disease. There's a colloquial phrase we use in the United States as clear as mud. And that really applies, right, to the tying together the clinical presentation with the genetics or the genotypes, right? So this phenotype-genotype connection is so important, right, in understanding any disease. In mitochondrial disease, the complexity is driven at multiple layers: the complexity of genetics, the complexity of the presentation, because really any organ in the human body can be affected by mitochondrial disease. And so it may be neurological symptoms, it could be cardiac symptoms, musculoskeletal symptoms. So all of these kind of combine together, and then you have this waxing and waning that is often present in mitochondrial disease, where the disease may progress very rapidly and the patients experience much more severe symptoms, and other times where there seems to be a stasis, right? A more level of control, right, of the disease. So makes it hard for the clinician to make a diagnosis, particularly if they're not turning to genetic testing early in the differential diagnosis. So that's one of the things we're really advocating, and I appreciate Paula, bringing up the fact that it's much more than just the doctors that are taking care of mitochondrial disease patients. It's all of the other specialists, like neuromuscular specialists, that undoubtedly a large portion of our patient community are wandering, lost in the diagnostic journey forest. And so if those healthcare providers aren't turning to genetic testing early in the process, they're probably not thinking about mitochondrial disease, right, as an option. So it affects the diagnosis of the patients. I think all of our groups are very focused on the rare inherited disorders, right? The primary mitochondrial disease, as we ultimately or usually refer to it. But we recognize that mitochondrial health, mitochondrial function and dysfunction is actually a key component of just the human health condition, right? So there are many patients out there, many individuals that have symptoms that are representative of mitochondrial disease because their mitochondria are not functioning right, but that does not mean that they have a primary mitochondrial disease. So we have a community, right, that is made up of those that have a very clear genetic diagnosis and have primary mitochondrial disease. This enables them to get better clinical care and ultimately participate in clinical research and hopefully get us to therapeutics, right, to address those patients. But for all the others, we have to continue to work on methodologies. And I know the UK has put a lot of effort into this as well. How do we increase that percentage? If only half or perhaps slightly more of our community have a genetic diagnosis, how do we continue to keep pushing that number up? Because ultimately, achieving a diagnosis is the key to better clinical care and ultimately access to therapeutics that are meaningful.
And practically, so both Maria and Amel mentioned about the ever evolving number of genes that are being identified. So those, things are being added to the list all the time. So what is the route for patients who may have been tested, say 5-10 years ago when their gene wasn't known and have been kind of somewhat neglected by the system because they don't have that diagnosis? Is there a process or a way for patients to keep kind of having another bite at it and saying, look, I want to be retested, or, what's the program for that? Because, and again, that draws into a question that we've been asked about those people that just feel neglected because they, as yet, the science hasn't caught up with them.
Yeah, from my perspective, it's absolutely incumbent on the healthcare provider to kind of stay in contact, right, with where the field is at. But this is very hard. There are over 7,000 rare diseases, right? And again, the clinical presentation of mitochondrial disease, primary mitochondrial disease, can significantly overlap with many other rare and common diseases. Right, so it's a bit unfair, right, to expect every healthcare provider to exactly understand the depth and the complexities of mitochondrial disease. So I think we come all the way back to where we started in the role of patient advocacy groups, right, for us to keep that awareness push on, right, and outside of our own little bubble, right, of mitochondrial disease to the much broader medical community, to make sure they know there are improved techniques, whole exome sequencing, whole genome sequencing. Even if you did a very early panel that perhaps had a handful of genetic markers, right, associated with it, it's absolutely worthwhile to come back and get genetic testing done again. So this will be a process. But you're absolutely right. The frontier keeps advancing, and that means that patient advocacy groups in close collaboration with the clinical community have to continue to make that push of awareness that there are new and better ways to diagnose this terrible set of diseases.
And I guess also that goes back to Paula's point about legislation and frameworks for funding from insurers and providers like that, because obviously if you're asking for repeat testing, then there's conversations to be had about the merit and the cost effectiveness of that. So not without complications. So Paula, to come to you, I mean, it's clear that a multidisciplinary collaborative approach is really required here. People may come at this from many different disciplines presenting with different symptoms. What's your kind of take on that as to how important that is and what that looks like?
Yes, these diseases, often complex and rare, involve dysfunctions in the mitochondria and the powerhouses of the cells. Given their wide range of effects on various body systems, diagnosing mitochondrial diseases can be incredibly challenging. This is where a team-based multidisciplinary approach becomes essential. Symptoms can range from muscle weakness, neurological issues to heart problems and metabolic irregularities. Because mitochondria are involved in all almost every major organ system. These diseases often are present, are overlapping with non-specific symptoms. It's not uncommon for patients to see multiple specialists over an extended period of time to get a correct diagnosis before they actually get a correct diagnosis. Why is it important to have, why is it crucial to have multidisciplinary collaboration? Consider the following scenario. A patient has fatigue, muscle weakness, and cognitive decline. The symptoms may seem to suggest a neuromuscular disorder, but mitochondrial diseases can masquerade as a variety of other conditions, such as neurological, metabolic, cardiac diseases, or other. And this is where a different specialist, neurologist, cardiologist, geneticist, endocrinologist, and others have to come into the field, basically. They need to come together to piece together the puzzle. Each specialist brings unique expertise to the table. A neurologist, for example, can assess the cognitive and motor impairment and identify early neurological signs. A cardiologist are critical in diagnosing any cardiovascular involvement, such as arrhythmia or heart failure, which are common in mitochondrial disorders. A geneticist is very important because they play a pivotal role in pinpointing the genetic mutations that cause mitochondrial dysfunctions in advanced genetic testing. Another one is the metabolic specialist. They are key to understanding and interpreting biochemical testing, especially when mitochondrial disorders affect energy metabolism. An ophthalmologist is also very important because often there are visual disturbances and other common manifestations of these diseases. By working together, these specialists can provide a comprehensive diagnosis, which might otherwise be elusive if each physician were to approach the patient from a narrow, isolated perspective. The role of early diagnosis and personalized care is also very important. A timely and accurate diagnosis is critical for patients with the mitochondrial diseases. Many of these disorders are progressive, and early diagnosis can make a significant difference in the patient.
Thank you, Paul. That's fantastic. And I think it's really coming through loud and clear how important that multidisciplinary approach in the clinical care is, but then also going back to what Amel was saying about that collaboration with the scientists and with the researchers and with that whole kind of ecosystem